Hello again. You are listening to the fourth lecture in Part 3 of this multi-part lecture series on the foundations of bioethics. Part 3 has focused on the emergence of bioethics as a discipline and on principlism as the dominant ethical framework within bioethics. In the previous lectures, we examined the historical birth of bioethics, the influence of the philosophers and theologians on the Belmont Report, and the development of principlism in the Belmont Principles as a guiding approach to ethical analysis. Having established that foundation, this lecture turns to a critical examination of principlism itself. Specifically, we will explore why ethical analysis in healthcare should not be limited to principlism alone, and how an exclusive reliance on this framework can obscure important moral dimensions of healthcare practice. In doing so, this lecture begins to clarify why the ethical theories introduced earlier in this course remain essential tools for analyzing bioethical dilemmas, rather than historical detours or theoretical abstractions. Following this lecture, you should be able to analyze the strengths and limitations of principlism, explain why and how principlism is often referred to as an algorithm for honoring autonomy, and discuss the concerns that current ethicists have with the universal application of principlism to moral and ethical dilemmas in healthcare. The understanding of principlism is often referred to as an Enlightenment ideal of a universal understanding that permits all people to make arguments for their own conceptualization of a good life. And furthermore, political and social arrangements should not permit anyone to impose their conceptualization of a good life upon another. So, in other words, principlism can be interpreted as a theory that emphasizes self-governance, liberty, rights, individual choices, and following one's own will. Thus, principlism quickly set the stage upon which powerful ethical arguments could be made and defended based on an individual vision of what constituted a good life. The Belmont Principles provided a principled basis
for the strong commitment to patient autonomy and a rejection of medical paternalism. The core principles underlying the Belmont Report and their applications have served for decades as a leading source of guidance regarding the ethical standards that should govern research within human participants, and more broadly, policies and decisions on a range of issues in the clinical setting, from truth-telling to informed consent to participation in research, advance directives, privacy, and confidentiality. Inevitably, all of these orbit around the right of the patient to make decisions about their medical care without the influence from the care providers. Driving most discussions about the core principles of the Belmont Report and their application is the overriding assumption that healthcare providers may educate patients, but should never make medical decisions for the patients. At the time of its development, Principlism was intended to be an objective, nonpartisan, and normative ethical theory that could be applied through all areas of healthcare. However, the theory did not live up to much of what it promised. Principlism was embraced as being a neutral and universal moral language for explaining what was good and not good, what should be done and should not be done by care providers in medicine. However, it was neither neutral nor universal. Principlism was speaking to a particular time in history and to a particular place. It was largely influenced by Western Anglo-American bioethics. All of the 4 principles within the Belmont Principles were intended to be taken into account, and no one of them was supposed to overrule another when analyzing an ethical dilemma. Each of these principles were to be prima facie, meaning always binding unless in conflict with other duties. However, what actually occurred was a dominance, a primacy, and an overemphasis of the principle of autonomy over all of the other principles within bioethics. Principlism was supposed to provide us a structure for analyzing and solving moral problems. However, through the use and application of principlism, it separated the individual patient from their social and temporal ties, from their community, and from their history, and it severed individuals from their source of moral meaning. Principlism was to be a method to address concerns about the concrete circumstances of clinical life. However, it was not concrete. It provided abstract principles that were very often open to not just multiple interpretations, but opposing interpretations. Like all ethical theories, principlism had its holes and its gaps. As we discussed, principlism provided a Western Anglo-American outlook on bioethics. The gap here is that principlism failed to take into account how race, culture, and religion shape one's views of medicine and therefore shape bioethics. Principlism provided the respect of autonomy of the self. However, it didn't ground the self in anything enduring, such as community or God. The self was simply the autonomous self. Principlism addressed the doctor-patient relationship or the healthcare provider-patient relationship from the viewpoint of the rights of the patient and the responsibilities of the care provider. However, the theory offered little insight on the responsibilities of the patient and the rights of the provider and society. Principlism has generally been adopted as the ethical framework for healthcare. Yet, at its very foundation, the theory provides nothing about the meaning of providing healthcare. And although principlism emphasized individual patient choice in medical matters, that the patient should have a choice, the theory was silent on the choices themselves and if there were any limits and how limits should be imposed on the choices patients are making, especially when those choices are in contradiction to beneficence, non-maleficence, or justice. In no way do I mean to conclude that principlism should fail as an ethical theory. Like all theories, principlism has nuggets of truth. It has strengths. It brought the language of individual rights into the clinical setting at a time when healthcare was ruled by paternalism. The 1979 Belmont Report gave patients a much-needed voice in decision-making and established a basis for moral consensus within a pluralistic society with both secular and sacred traditions. But, like all other theories we have discussed, principlism had gaps. It had holes. It left bioethics unmoored from the larger questions of human nature and reality, the questions surrounding truth and meaning, surrounding transcendent values and destiny. Instead, principlism overemphasized patient autonomy and de-emphasized the principles of non-maleficence, beneficence, and justice. And as we're going to learn throughout the rest of this course, that most of the ethical issues and dilemmas that you're going to be faced with are more complex than simply honoring an individual's autonomy. So, while principlism can work as an ethical theory, it cannot work in isolation without the consideration of additional ethical theories.
At its core, principlism boils down to an algorithm for honoring autonomy. The theory is procedural, legalistic, and stringent. Thus, it can lead to us as humans feeling betrayed when we adhere tightly to the rules and regulations of principlism. This is because people aren't mathematical formulas. You can't break a healthcare dilemma down to numbers and patterns. Every person's situation is unique and requires context-sensitive judgment that an algorithm just cannot provide. To help explain this better, on the next slide, I'm going to read to you a case study from pages 111 to 112 of the textbook Bioethics in a Cultural Context by Vincent Berry. I encourage you to close your eyes and just listen. The patient was a 17-year-old girl from an Orthodox Jewish community on the East Coast. 3 weeks prior to her hospitalization, the young woman had consulted with her rabbi about Jewish laws covering her upcoming arranged wedding to a young man she'd met only once. In the medical phase of marriage counseling, the woman was found to have a dysfunctional uterine bleeding, which subsequently was tracked to uterine cancer. Dr. John Lantos and his colleagues recommended radiation followed by a hysterectomy, which would leave the woman infertile. But the young woman's father feared that the news would devastate his daughter and jeopardize the wedding, so he requested that she not be told that the treatment would leave her infertile. Of the decision he faced, Dr. Lantos writes, "In one sense, it was easy. Informed consent, respect for persons, truth-telling. From a risk management point of view, it was a no-brainer. You tell her. If she refused treatment, that's her choice. It may be tragic, but it isn't tort. Treat without consent, and she sues later. It is at least malpractice, and maybe even assault and battery." From a principlism perspective, then, the right course of action seemed clear-cut. Tell the patient the whole truth. But on second thought, the matter was a bit more complex. Whose interests were paramount, the patient's or the hospital's? And what about the principles used to decide? The Belmont principles were neither timeless nor universal. Had the young woman not been in the United States, for example, or had it been a few decades earlier than the 1990s, perhaps nobody would have told her. She was, after all, a minor, and her concerned and sincere parents had the legal right to decide for her. Then there was the matter of her religion, which didn't acknowledge the primacy of autonomy. As her father said, she must have treatment. Law requires it. Why add to her suffering now when she needs hope and strength? When the young woman was told the whole hard truth, she said she didn't want the treatment and stormed out of the room, leaving Dr. Lantos questioning his decision. Did we do the right thing? We followed all the rules. Our actions were based on our adherence to the most idealistic moral principles. In a certain sense, what we did was unassailable. In the most difficult and trying circumstances, we had confronted ugly truths instead of hiding from them. We had helped a patient who clearly had the capacity to make her own decisions, to understand the choices before her, and to make a choice based on her own deeply felt moral values. This was a triumph for patient autonomy, for feminism, for children's rights, a culmination of 25 years of work in health law, civil liberties, and bioethics. But it felt as if we had betrayed everything that medicine stands for, and had become zealots in a cause that looked less like moral excellence and more like political dogma. Although Dr. Lantos did what he ought to have done according to principlism, in retrospect, he is not persuaded that he best served this young woman. In fact, he feels that he placed physician and institutional values and interests above the patient. Although he studiously acted on principle to avoid wrongdoing, both moral and legal, he somehow feels that in this instance, he and the philosophy of principlism failed the test of moral excellence.
Dr. Lantos is hardly alone in feeling betrayed by principlism. For many healthcare providers who have spent the time and effort to really understand this ethical theory, it is often considered that doing the right thing is nothing more than a risk management strategy to avoid civil wrongs such as tort, malpractice, assault, and battery. In other words, following the rules is not the same thing as moral excellence. Following the rules is not doing what is wrong. Moral excellence goes one step further and looks at doing what is right. And if you recall, there's a difference between what is right and what is correct. And when what is right and what is correct by the law don't always align, that is where we have to ask, does principlism fail the test of moral excellence? Will principlism lead us to doing what is right, or just lead us to doing what is legal and what will mitigate risk?
As ethicists continue to evaluate principlism, there's a growing consensus that limiting the analysis of ethical dilemmas to principlism produces, as Vincent Berry refers to it, very thin gruel. If principlism reduces ethical analysis to a checklist and autonomy becomes the final authority, we must ask what is being lost in the process. Illness is not experienced as a series of rational choices, but as vulnerability, dependence, and moral disruption. When ethical reasoning stops at consent, it risks mistaking permission for moral justification. If autonomy is treated as the highest and sometimes only ethical good, whose voices, values, and moral responsibilities are being silenced? Is there a way to not get rid of the good nuggets of truth and principlism, but still remain cognizant to what principlism is leaving out of the equation?